Hi, this is Corey Hudson from MedStar Sports Medicine, and we're going to do a talk today on the evaluation and management of respiratory and allergic emergencies in the sports medicine setting. I have no relevant financial disclosures, but I would like to thank MedStar Sports Medicine and my colleagues on the Emergency Action Planning Group, Matt Sedgley and Amber Radke. Our goals and objectives today, we're going to define respiratory emergency, we're going to review some cases, we're going to talk about the initial assessment, we'll review some tips, tricks, and tools you can use on the sideline, and we'll review some specific conditions that we see in sports medicine that are important to remember when evaluating the athlete with a respiratory emergency. First and foremost, we want to think about what is a respiratory emergency. And I think about it simply as any event that threatens a patient's ability to adequately oxygenate or ventilate. And it's important to think about both. Are they getting enough oxygen in, and are they getting enough carbon dioxide out? These events may be minor. They may be really nothing serious. It may be a little bit of hyperventilation, or they can be really critical. Those critical events are rare, thank goodness, but we need to prepare for them, because when the critical events happen, if we're not ready, they truly can be life-threatening. So here's our first case. We'll call her the Wheezy Runner. She's a 16-year-old female on the high school cross-country team. She has a history of asthma that's usually mild and really well controlled, with only the rare use of a rescue inhaler. She doesn't take any daily medications. She's at the state cross-country meet in November, and at the finish line you see that she's really struggling. She's clearly dyspneic. She's very short of breath. So I want you to think to yourself, what do you do when you see this short of breath young female runner crossing the finish line in a November track meet or cross-country meet? Case number 2 we'll call trouble in center field. So this is a 20-year-old male collegiate baseball player. He's an outfielder. He saw several bees near the fence. He felt a sting on the back of his neck. He runs to the dugout because he's worried about having an allergic reaction. As the athletic trainer, you call the physician, or if you're the physician, the athletic trainer calls you in a panic, wondering what do you do next. So if you are the athletic trainer, I want you to think about what do you do next, or if the athletic trainer is calling you as the physician, I want you to think, if you're on the other end of the phone, what are you going to tell them, and what do you want them to do as the next step in the evaluation of this baseball player who may have just been stung by a bee in the outfield. The last one was a 38-year-old American Hockey League official who drops to the ice after he's hit in the neck with a puck after it was a shot on goal from the team's new first-round draft pick. So this great draft pick trying to make a good impression takes an amazing slap shot, just takes a bad hop, and the official is in the wrong place at the wrong time, and he gets struck right in the anterior neck. He's tripoding on the ice. He's awake, but he's struggling to breathe. He's clearly short of breath. He's clearly in distress. You're the healthcare provider. They're rinkside. What are you going to do next? So let's start with the basic evaluation and treatment algorithm. And these are true pretty much regardless of the injury, but let's think about it systematically. And number one is we think about the history of present illness in the event, and we just went through those with the cases. We want to do a brief exam, and when I say a brief exam, and we're talking about shortness of breath, this is a brief exam. We are going to get in sort of our A's, B's, and C's, and then we're going to move on. We want to think about what interventions we can make and what interventions we can make quickly, and then we want to reassess. And as an emergency physician myself, first and foremost, I kind of dumb this down a little bit and think if you make an intervention and it makes things worse, the first thing you got to do is undo that, right? If you make an intervention and make things better, great. Watch and let's see how things are going. Things are getting better. Let's sit back and do a little bit of nothing for a while. If things are getting worse, got to come up with a new plan. And then transfer as appropriate, right? With respiratory emergencies in particular, you want to make the decision early. Does this person need to be someplace else? Are we remote? Are we far away from a hospital? We need to get to a hospital. You want to call 911 right away. You want to be getting yourself back towards the athletic training room, back towards a phone, back towards civilization if you're far away. Or even if you're in the city, you want to think to yourself, how close are we to that closest hospital? And do we need to be moving that direction pretty quickly, right? We don't want to be sitting on the side of the tennis court or on the side of the baseball field when this patient with mild respiratory distress ends up in severe respiratory distress, because that downturn can happen pretty quickly. I borrowed this from pediatrics, but I think it's really useful here as well. When we're doing this initial assessment, I want you to, again, simple here. We want to think about generally, how do they look? What's their appearance? What's their mental status? Are they talking? Are they interacting with us? If their mental status is bad, altered, if they're not able to speak, if they're not able to interact, these are not good signs. We need to up the ante really quickly. How's their work of breathing, right? Are they having labored breathing? What's their position? That hockey official we mentioned, tripoding, he's down on his hands and knees. He's really working hard to breathe. Are we seeing retractions? Are they using their abdominal muscles and their neck muscles in order to actually try to get more air in? Are they apneic? Have they actually stopped breathing? Or are they gasping for breath? Again, bad signs. We got to really pay attention to what does their breathing look like. And then circulation. Right? At this point, we're going to assume these patients have a pulse, because if they don't, we're on the wrong algorithm. We got to get to our CPR algorithm. But assuming they do have a pulse, what does their skin look like? Is it pale? Is it cyanotic or blue? Is it mottled? Does it have that sort of lacy bluish purple look to it? Is it cool to the touch? All of those signs are signs that they're not getting good perfusion or that they're not oxygenated well. Again, those are signs that this respiratory distress may be worse than it appears on the surface. It may be really pretty bad, and we may be getting ready to head into circulatory collapse. Remembering, of course, that all of those skin findings may look and feel different on people with different skin tones. And so a fair-skinned Caucasian person is going to have that bluish coloring that's going to be really obvious, maybe all over their skin. When you've got someone with a darker skin tone, you may have to look more closely around their lips, more closely around the eyes, more closely at the nail beds to see the changes in skin color. You want to look and feel. You're going to feel for that coolness. You're going to feel for that diaphoresis or clamminess of the skin. Those are going to be your signs here. But pay attention to the skin as well as the work of breathing and the general appearance. That's your initial assessment. When we're thinking about airway management and airway interventions, the things on this slide are things we do when the patient is pretty much unconscious or minimally responsive. First one here is a jaw thrust, shown on the left. A proper jaw thrust technique is not straightforward. It actually takes some practice. So the next time you're in a CPR class, I recommend you practice this jaw thrust. You want to get your fingers under the angle of the mandible, right there up under the TMJ. And for the supine patient, you want to think about lifting that jaw towards the ceiling or towards the sky. That jaw is coming up off the tongue, off the posterior oropharynx, and lifting it up towards the sky. Right? We're not going down towards the sternum. We're going up towards the sky. The best way to do this is with two hands. It's going to be one hand on either side of the jaw and lift up. And then if you're going to use a bag valve mask, as shown as that second picture and third picture, you're really going to need a second person to help you. So one person is lifting the jaw and making that good seal, getting that mask tight to the face, and the second person is going to be squeezing the bag slowly. That breath goes in over 1 to 2 seconds, which means we're squeezing the bag slowly, we're letting it release slowly, and then we're waiting 8 to 10 seconds in between before we squeeze the bag again. When you're squeezing the bag, you want to watch the chest rise, watch it fall, and then rest. It is hard to do this at the right pace. We are anxious, we're worried, our pulse is up, our blood pressure's up, our own respiratory rate is up. We have a tendency to want to squeeze that bag at the same rate that we're breathing, and it just doesn't work for our patient. You have to do this slowly. Force yourself to slow down. 2 people, good technique. And then think about the use of an airway adjunct. EMS should have these, even if you don't, but again, you can help them use this. An oral airway, a hard plastic oropharyngeal airway. Remember, this is a C-shaped airway shown here on the right-hand side, on the top. We put it in upside down, so with that curve, so that it actually is sort of curved towards the hard palate or towards the top. And then once it's in the back of the oropharynx, we flip it over so it's into the position you see here. It should not push the tongue back down, but should in fact lift the tongue up off the back of the oropharynx and should provide a little bit of a bite block so our patients are not biting their tongue. The nasopharyngeal tube, the NP tube, goes in through the nose, through the nostril or the nair, and with the bevel towards the septum. and with a little bit of Surgilube so that it doesn't stick. And then you slide it down through the nasopharynx and into the airway as shown here. And both of these will help with your supplemental oxygen, help keep the airway open a bit. Those really need to go in patients who are minimally responsive or unconscious. They're very uncomfortable, so the responsive or awake patient is not going to let you put those in. They take some practice. So again, the next time you're in a CPR class or a first aid class where you've got your resuscitation mannequins like these, ask to practice these skills. A couple other tips and tricks here. If your patient has altered mental status but you're not concerned about trauma, you can use the head tilt chin lift. You can actually just extend the neck backwards and lift the chin up sort of as an extended mechanism. That's going to help get that tongue off the back of the oropharynx and will open up the airway. But again, you don't want to do that if you think your patient has any possibility of a cervical spine injury. The jaw thrust we discussed, if you don't know or if you think there might be a cervical spine injury, you want to use the jaw thrust technique. That nasopharyngeal and oropharyngeal airway we discussed just a moment ago help you maintain that patent airway. A pulse oximeter, we've all become very familiar with these recently during the COVID pandemic, but it's a way to indirectly measure the oxygen saturation of the blood with a simple non-invasive method where we can use on a fingertip or on an earlobe. Supplemental oxygen is really only necessary if the O2 saturation is less than 93%. So we really don't need extra oxygen unless that oxygen level is low. There's very little value to providing extra oxygen or hyperoxygenating patients, and in some cases it may actually be detrimental. And invasive airway maneuvers are best left to EMS or in the ER. So things like the King airway or the new iGel airways, endotracheal intubation. We put a lot of emphasis on those in the past, but over time we've learned that really we spend a lot of time on the airway where we might actually make things worse, and we're ignoring other parts of care which may be more important. So we don't want to delay transport to the hospital for an airway maneuver which has not been proven to give us benefit and may actually worsen outcomes. So these basic life support maneuvers have been shown to improve outcomes in everything from mild respiratory distress all the way up to cardiac arrest. Equivalent or improved outcomes without these invasive paramedic level or physician level airway maneuvers. So skip the invasive stuff, do the basic stuff well, get your patient where they need to be. Let's talk about some very specific cases here. So asthma. Initial treatment for asthma we want to consider our inhaled bronchodilators. This is largely our beta agonists, so like albuterol. So brand names Ventolin, ProAir, and then there's levalbuterol, which is Zopanex. There are some anticholinergics like ipratropium or Atrovent. These are usually given as meter-dose inhalers, but they can also be given as a nebulizer treatment. In the outpatient setting, most of our athletes are going to have their own meter-dose inhaler. If that's what they're going to use, make sure they use a spacer, which is shown here in that lower right-hand corner, that make it more effective. Most athletes or most patients have been prescribed a spacer. They've been given a spacer. In my experience, most of them don't have it, don't use it, don't know where it is. But anybody who's ever used an inhaler, a regular meter-dosed aerosolized inhaler, knows that the medicine doesn't taste very good. The fact that we all know that means that we're spraying a lot of those particles onto our tongue. Those large droplet aerosols are ending up on our tongue. They're not making it into the fine mist that we're able to actually inhale. The spacer is what allows for that. So if you don't have a spacer, you can make one out of a plastic bottle. So just get a plastic water bottle, cut a hole in the bottom of it, put the inhaler in that hole in the bottom, and then have them put their mouth on the part that you would normally drink from, have them put their 2 puffs into the bottle. Again, that lets that fine mist form, and then they can breathe that fine mist from the end. It's not perfect, but it's better than spraying it all onto their tongue. Advanced treatments for asthma would be to, again, use oxygen if their sats are low, call EMS if the patient is not responding to that initial treatment. They may need IV fluids or BiPAP, bi-level positive pressure ventilation, sometimes steroids, oral or IV magnesium in very severe cases, and sometimes epinephrine helps as well. Inhaled steroids and long-acting beta agonists have traditionally not had any role in acute symptom management, though there are some newer formulations of that may be rolling out in ways that may be more effective. So traditionally, we said inhaled steroids and long-acting beta agonists are used for maintenance therapy and sort of as a prophylactic, but there are some newer versions which are showing some promising treatment here. So that brings us back to our case number 1, the wheezy runner. So when we check her vital signs, her heart rate's 110, her O2 sats are 92%, her respiratory rate is 24. She does have her own albuterol inhaler, and we're able to coach her to use 2 puffs using a water bottle as the spacer. We repeat those 2 puffs again 5 minutes later without much improvement. So now she's had 4 puffs of her inhaler. She's still pretty wheezy. Her vitals are about the same. EMS arrives and begins a continuous nebulizer treatment with some supplemental oxygen. Her parents are notified, and they agree with your plan to transfer her to the ER. So again, because she's still wheezing, because she still sounds tight, she's still tachycardic, she's still hypoxic, right? Her oxygen levels are still low. After 4 puffs and now 5 or 10 minutes, it's time to get her to the hospital so we can get some additional treatment. Realistically, she probably just needs a little more time. She needs a little bit more albuterol, maybe a little bit of steroids. She's, in my experience, going to do just fine with this. But it's just going to take a little more time to turn around, and it's probably better to have her at the hospital than to sit with her on the finish line of the cross-country meet. I will point out here again, remember this was a minor, so before we do too much of this, we want to talk to our parents. Emergency and life-saving treatments, we can go ahead and initiate. Don't wait to save someone's life because you need to call their parents first and try 6 phone numbers and wait for them to call back because they didn't answer your phone number, which they didn't recognize. Treat the patient first if there's a life threat, but once you know there's no immediate life threat and things are stabilized, you do want to go ahead and call the parents, and certainly as you're transporting her before you transport the patient to another location like the ER. All right, let's talk about anaphylaxis a little bit. So anaphylaxis occurs when exposure to an allergen leads to a specific reaction. So most common reactions are things like foods, bees, certain medications, though in many cases we don't know what the exposure of the allergen actually was. To be truly an anaphylactic reaction, we need to have 2 or more organ systems involved or hypotension, low blood pressure, with a known trigger. So if I'm known to be allergic to shrimp and I eat shrimp and I have wheezing, not enough. If I have allergy after shrimp and my blood pressure is 60/40, I don't need to have any other symptoms. Being hypotensive plus knowing I was exposed to shrimp and I'm allergic is enough. Eating shrimp, being wheezy, and having hives, I now have 2 organ systems involved. I have respiratory and skin, right? Don't forget that GI counts, so people who have nausea and vomiting, that's one we probably don't count enough. Altered mental status, which includes anxiety and confusion, but anxiety is one we don't count often as we should. So organ systems are really broadly categorized here. So respiratory, skin, cardiac, including tachycardia or hypotension, GI, altered mental status, or neuro, count broadly here. Initial treatment options should include IM epinephrine and call 911, right? Number 1 and number 2, call 911 and use IM epi. If the patient has an EpiPen or epinephrine autoinjector, please go ahead and use it. Adjunctive options include things like antihistamines, so H1 and H2 blockers, steroids, maybe glucagon, maybe albuterol and oxygen. There's a lot of debate about the use of these. H1 and H2 blockers may help with the hives, but generally don't help with the any swelling of the mouth, lips, or tongue, or the respiratory symptoms. H1 blockers are things like Benadryl. Those are your typical antihistamines that you think of, Benadryl, Claret, and Zyrtec. Benadryl is what we've typically used, but there's really no data to suggest that it's any better than the others, and it may be more sedating and have other side effects, anticholinergic side effects, which are unnecessary. So there's really no value in Benadryl over the others. The H2 blockers are the ones we typically think of as stomach medicines. These are things like ranitidine or famotidine, Pepcid, and Zantac. And so those are medications that, again, we think of them as GI, but really they block a second type of histamine receptor. And again, they may help with urticaria or the hives, Not going to help with the respiratory symptoms, probably not going to help with any angioedema, swelling of the mouth, lips, or tongue. I put that in the category of might help, not going to hurt, so we might as well give it a shot. Glucagon may be helpful in patients who are on beta blockers or ACE inhibitors. So your older patient or your patient with hypertension who's on a beta blocker or ACE inhibitor, who has severe or refractory anaphylactic reactions, the glucagon may help with block their medication so that the epinephrine and some of the other medications work a little better. Basically, their baseline antihypertensives may be working against them in this case, and so the glucagon is basically going to help our medications be more effective. Albuterol is going to open up the airways, bronchodilator like we spoke of before, and again, oxygen is just to treat any hypoxia that's happening from that bronchospasm from the closing airways. But epi. You can repeat the epinephrine in 3 to 5 minutes if they need a second dose. But call 911 and get them to the hospital. If they need epi, they really should be going to the hospital. So that brings us back to our case number 2, the trouble in center field. Our baseball player confirms that he is allergic to bees and wasps, but he forgot his epi auto-injector at home. He has hives, urticaria, forming on his neck and trunks and arms. You can hear him wheezing, and he's complaining that his throat feels itchy. The athletic trainer, you have an EpiPen in the kit, and so if you're the physician on the phone, you tell her to go ahead and administer that 0.3 milligrams IM. So that's the adult-sized epi auto-injector, the standard EpiPen, and have the coach call 911. As EMS gets there, they're going to give IV steroids. Typically, Solumedrol is what they'll give, and IV diphenhydramine, that's Benadryl. Patient has his symptoms improve as he's on his way to the ER. All right. Even as an emergency physician who does a lot of time preparing for and training for emergency airway situations, I got to tell you, this is the one that probably worries me the most. So the traumatic airway. Tracheal and laryngeal injuries are often associated with stridor and hoarseness and subcutaneous emphysema. You can actually have tracheal transections, which can happen with blunt force trauma, or it can happen with penetrating trauma, right? You can have a tracheal laceration or a laryngeal laceration. Vascular and soft tissue injuries are common with blunt force trauma to the neck. You can get a hematoma that forms, or you can get a bruit that you can actually hear across the neck if you're in a quiet enough place to listen. And don't forget that your cervical spine injuries. So C3, 4, and 5 keep the diaphragm alive, so that your cervical spine injuries can lead to respiratory failure as well. So this brings us back to our case number 3. Our hockey official has an expanding hematoma to the anterior lateral neck. This is like my nightmare scenario, is worried that you're going to have somebody with an expanding hematoma in the neck. EMS is activated. Our official does not have any midline spine tenderness and no neurologic deficit, so we're not worried about a cervical spine injury. There's no sub-Q emphysema, so we're not as worried about there being a laryngeotracheal injury or a tracheal transection. In a case like this, we want to transport him in a seated or semi-recumbent position, truly in a position of comfort. You want to let this athlete or this patient get himself in the position where he feels like he is getting as much air in as he can. Put him however he is most comfortable, and let's get him to the trauma center as quickly as possible. You want to prepare for an invasive airway, and if that's not in your tool bag of skills, you want to have a paramedic with you whose skill set it is, or a physician with you who has that skill set, or you want to just make sure that everybody knows you need to be headed to a trauma center where they are ready for that. You want to use the term soft tissue neck injury, expanding hematoma, impending airway disaster. Use whatever terms you need to when you call ahead and tell them that you are worried about this airway and that they need to be worried about it too. Coming to a trauma center, this is the place where I don't want to be there as the emergency physician managing this airway. I want all hands on deck. I want the trauma surgeons. I want the anesthesiologist. I want the head and neck otolaryngologist there with me. I will call in the cavalry because there's no pride in an airway like this. We need to have everybody present to help because again, if these go bad, they go bad quickly. So be ready for badness, and let them support themselves in a position of comfort with supplemental oxygen as you go fast to the hospital. And so that brings us back to reviewing our algorithm. So we do our initial assessment, that initial evaluation with the triangle. We intervene, right? So we start with some basic interventions like oxygen or maybe albuterol, maybe an EpiPen. We reassess to see how our athlete's doing, right? Did they get way better? If that runner in case number 1 got better after her first dose of albuterol, she probably doesn't need much more, right? She's better. We can watch her for a little bit and she can probably go home later. If she doesn't get better, we need to think about what's next. Same thing with all of these patients, right? We reassess after we do an intervention. Are they better? Are they not better? What's next? Then we need to think about whether or not they need to be transported. Do they need to be at the hospital? And if so, let's get them there quickly. So in conclusion, airway emergencies are a high-stress situation. There's really very little in what we do that's harder than watching somebody struggling to breathe, right? Watching somebody who's having a hard time breathing is one of the most difficult things as a care provider. And so I think practicing those what-if scenarios or thinking about those. So when you're on the sideline thinking, what would I do right now if somebody got stung by a bee? What would I do right now if somebody had a severe asthma attack? What would I do right now if one of my athletes got clotheslined and had a tracheal injury? Game those situations out in your head so you can think about what would come next and what would come next and what would come next. And again, if you don't have EMS there, call for transport early. Don't get caught sort of on your heels behind the game. Be ready to go. As always, thanks for your time. I'm always open to questions. Feel free to email me anytime. Everybody get out there and practice. Think about your emergency action plans and keep taking great care of your athletes. Thanks so much, everybody. Have a great day.